Thanks everyone for attending today. My name is Paxton Buck. I am the program director for the Addiction Medicine Fellowship Program, and this is our last What's New in Addiction Medicine for 2025. Yeah, applause. So it gives me great pleasure to introduce today one of our fellows, Dr. Adam Arthurs. Dr. Arthurs is one of the PGY5 emergency medicine residents here, one of our current addiction medicine fellows. He completed his med school at NOSM before coming out here for residency. And the concurrent addiction medicine fellowship. He's going to be talking to us today about a subject that I think is very topical, and one that I get asked questions about a lot, and that is about buprenorphine beyond the product Monograph. What do we know about the ways that buprenorphine is being applied these days that goes beyond what is sort of the established guideline-based approaches? It'll take 45 minutes or so for the talk, and then we will have questions at the end. So thank you.
Okay, let's get started. So before I fully get into the presentation, I want to acknowledge that I just want to acknowledge that I am a white settler on the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. I'd also like to acknowledge that Indigenous patients, as you'll see in some of the literature that I'm going to be presenting today, are both underrepresented in the literature, but despite this, face many socio-demographic limitations that prevent them from having really high quality of health within Canada itself. And they are some of the highest risk patients that we see for different conditions. And specifically when we're speaking about overdose, they're one of the highest represented patient populations, despite them not being the majority of the population within Canada. I'm going to skip through the overview. Basically, we're going to be talking about a lot of stuff related to buprenorphine. Specifically, we're going to be talking about macro dosing and different settings of using buprenorphine pre-hospital. In terms of the current literature these days and what opioid use looks like within BC specifically, between 2016 and 2025, there are a total of 203 or more thousand reported opioid-related poisonings that presented to the emergency department. There were also over 5,000 opioid-related poisonings that were reported within the first part of this year, so from January to March, and 85% of those were accidental opioid toxicities. And with this as well, there are over 7,000 calls to pre-hospital services for suspected opioid toxicity just within the first 3 months of this year. So opioids, as everyone within this room is aware, is very prevalent, and it's integrated within every part of the medical practice that we have these days. Some studies have shown that after adjustment for patients that are discharged from hospital, there's a 12-month mortality hazard of 3.5 times higher among those that present with overdose-related visits than those that present with non-overdose-related visits. For people who left prior to advised medical discharge, they are at an even higher risk of mortality with a hazard ratio of 7.1. This leaves kind of an ever-lingering question about how can we optimize the care that we provide these patients, because they are some of the highest risk patients that we see in terms of morbidity and mortality, both in an inpatient emergency department and a pre-hospital setting. In terms of this is just outlining the differences. So from a general population, we would expect them to have a near, under 100% probability of survival. The dotted blue line is representing patients that are discharged by a physician and presented initially with opioid-related toxicity. And we see an even lower probability of survival for patients that self-initiate discharge from hospital. When we look at reasons why this is happening and why patients are leaving the emergency department or the inpatient services, really it can be distilled down to 4 common themes. Ultimately, patients report that we are undertreating their withdrawal and that they have ongoing cravings for drugs. There is an uncontrolled amount of acute and chronic pain with an overlap of their substance use, and that there is prevalent stigma and discrimination within our hospitals, within our health staff that are reported by these patients. And ultimately, restrictions for patients in terms of the ability to leave their floors, to use, so on and so forth, have impacts on whether or not they're going to stay within our hospital. An additional study was a retrospective cohort study that looked at the probability of overdose-free survival of patients. So this is another Kaplan-Meier curve, which is comparing, so in terms of this first one, between 2015 and 2019, this is looking at our survival analysis to compare the rate of fatal or non-fatal illicit drug overdose in the first 30 days after physician advised and patient self-initiated discharge. So we see even after adjustment, there is a significant difference between patients that self-initiate discharge and subsequent overdose. In terms of current OAT dispensing practices, patients are initiated on medications for opioid use disorder after non-fatal overdoses, and seeing this done in the emergency department is not uncommon. Generally, this has been documented to show a lower overall risk of subsequent non-fatal or fatal overdose. And after that initial dispensation and prescription in the emergency department, about 1 in 40 patients follow up and receive a subsequent OAT dose within 1 day of leaving hospital. And we see that over time, that trend generally decreases over time, leading up to, for example, 12.5% in patients at 30 days from discharge. So ultimately, the overarching question, how do we improve patient care from time of overdose to the time of discharge from the emergency department or the hospital in general? Enter buprenorphine. I will not belabor this because generally most people in this room probably have some understanding of buprenorphine. It is an active ingredient in the medications that we prescribe, like Suboxone, which would be a combination of buprenorphine and naloxone, as well as Sublocade, which would be a once-a-month injectable form of buprenorphine. It's a synthetic opioid initially derived in the 1960s and was initially brought to market specifically as a safer alternative to opioids as an analgesic medication, but since then has also been approved for the use of opioid use. It's a partial mu opioid receptor agonist. It has very high binding affinity, meaning that it's going to bind with a high affinity and in a very sticky way to the mu opioid receptors. And generally, we see that it has a rapid sublingual absorption and effect, which is generally within 30 to 60 minutes, where we can see patients having the sensation that they're feeling the effects of Suboxone or buprenorphine. And that's going to peak around 1 to 4 hours and subsequently have about a 38-hour half-life via sublingual administration. Multiple formulations, I won't get into it, but if there is sublingual, there are buccal formulations, tabs, films, and also injectable forms, both subcut as well as IV. And really what's available is going to depend on where you practice. It's liked among people because it has fewer drug-drug interactions. And generally, in the initial studies that were done when this was coming to market and subsequently when they were looking at respiratory depression with buprenorphine, they found that higher buprenorphine levels measured in the serum may have a protective effect against fentanyl-induced respiratory depression. And generally, the primary risk that most people are concerned about when they are thinking about giving buprenorphine is the risk of precipitated withdrawal. If we think about different types of opioids, we have full agonists, which provide a full stimulatory or agonism effect at the mu opioid receptors, things like fentanyl, methadone, and generally have no to a higher ceiling effect, as compared to partial agonists, which will have less of an opioid effect at the receptor and will have a ceiling effect, especially for respiratory depression, versus antagonists, which we can consider having no agonist activity. If we think about the effect that when someone is used to opioids within their system, their receptors are used to having fully covered receptors, and the effect of this being that they perceive that as their normal and their new homeostasis. When people are using a full agonist, if we were to administer something like naloxone, we are essentially bumping all of those opioids off of the receptors, replacing it with an antagonist. And the subsequent change is what we see with withdrawal that they experience. So for patients that are being reversed with naloxone, oftentimes we will see essentially a precipitated withdrawal following administration. Similar type of idea for patients that are receiving full agonist. If they are to receive a partial agonist and they have tolerance and dependence, if they have some of those full agonists displaced and replaced with a partial agonist, they will, to varying degrees, experience withdrawal, depending on what percentage is displaced. Common ways that we get people onto buprenorphine involve a standard induction, a micro induction or a low dose induction, as well as what we'll be talking about primarily, which is a macro induction or a high dose induction. Standard and traditional is helpful for patients that are able to enter themselves or accept the fact that they're going to go into withdrawal or present to the emergency department in withdrawal. Limitations being that typically the recommended first aid dose is 12 milligrams. And in the era of fentanyl, we expect that this typically does not fully treat a patient's withdrawal symptoms and subsequently takes more than 1 day for them to reach a therapeutic OAT dose. In comparison, microinductions allow us to give patients very small amounts and displace very small amounts of the receptors so as not to shock the system and lead to withdrawal. And the effect of this is that patients can continue using full agonists, and then slowly over the course of 3 to 7 or more days, we can cover the receptors with buprenorphine without inducing precipitated withdrawal. Macro inductions generally are going to be where patients are presenting truly in withdrawal, and we are hitting them with high doses of buprenorphine upfront. The initial dose is going to be much higher, and the total first aid dose is going to be much higher. When we consider this, generally the generally accepted definitions is that that initial dose is going to be between 8 and 32 milligrams as their first dose, and that the day one total is generally over 12 milligrams total, which kind of defines a high dose. Generally, we see that this is designed for patients that are using a high potency or high tolerant opioids, things like fentanyl, but need to be used in a cautious way, specifically in the case of fentanyl and other forms of OAT. We also see that it's used in the emergency department for patients presenting with withdrawal in order to stabilize and rapidly treat withdrawal. And we also see that it is a fast way to get someone on a safe form of OAT within a very short time frame. So many benefits, and generally this is something that is starting to be introduced in case-by-case basis, but is not standard of practice or a truly documented guideline as to how to do this. We typically see that the two scenarios where patients will undergo a macro induction or a high dose induction are for patients that present to hospital after experiencing withdrawal from cessation of opioids. And the amount of time that a patient needs to be abstinent from opioids to be actually considered for a high dose induction and to have a low enough risk of precipitation is going to depend on the opioid that they're using. In the case of things like methadone, typically they're recommended greater than 72 hours since last dose. In the case of fentanyl, typically between 18 to 24 hours are recommended before they receive a dose, a high dose of buprenorphine. The other scenario where we see this being used is in patients that are reversed with naloxone post-overdose to manage withdrawal symptoms and to engage them in the pre-hospital setting. One of the initial studies that came out of this is that outside of individual case reports or real life experience, one of the first papers to look at this was published in 2021. It's a retrospective case series of encounters within the emergency department, and data was abstracted from emergency health records for all patients that presented to the emergency department with opioid use disorder treated with buprenorphine and considered to be a high dose of buprenorphine. It was in a single urban safety net hospital within California, and the total patients enrolled were 579. When we look at this study, patients included were patients over the age of 19 or equal to that age, and they were treated with sublingual buprenorphine for opioid withdrawal. And there was a consideration in this protocol for excluding patients that had complicating factors, which is an extremely long list. And if we consider all of those factors, it would actually represent a very niche patient population that we don't typically see. That being said, this was a suggestion to specialist consultation to see whether or not they should be included in the study. It did not actually exclude them from the study. So what we saw here was that once patients were identified to have an uncomplicated opioid withdrawal presentation, we had considerations of when their last use was and what substance they were using to then guide whether or not they would be included. They then had a COWS score that was applied to determine the severity of their withdrawal. And then if they met all of those criteria and their COWS was greater than or equal to 8, they received an upfront dose of 4 to 8 milligrams sublingually, had a repeat reassessment, and from that point onward, depending on how severe their withdrawal was, they were either by the physician discretion continued on a standard or traditional dose induction of buprenorphine, as we mentioned before, or they were considered for a high dose induction with typically doses in this case with a maximum over 32 milligrams over the first day. Initial outcomes that were looked at were to see whether or not this was safe and whether or not this was something that would increase a patient's risk of precipitated withdrawal, and also to look primarily at whether or not this would increase their risk of sedation, hypoxia, bradypnea. So multiple serious adverse outcome measures which were used. And then following this, data was abstracted to independent people abstracting the data blinded to each other's abstraction. And then throughout the study, inter-rater reliability was assessed and documented. Big table, you'll have to trust me somewhat, but essentially the primary results that came from this study when they were comparing doses of 8, 10 to 12, 6, 16, or 20 to 24 or greater than, compared to the lower dose 2 to 4 milligrams, were that there were no cases of respiratory depression. There were no cases of respiratory depression documented at any dose or sedation at all doses. There were a total of 5 cases of precipitated withdrawal in a patient total of 579. This was not associated with dose, and the 4 cases typically were identified in patients that received a dose of 4 to 8 milligrams as an upfront dose. Oxygen was administered to some patients, but on chart review, this typically correlated with patients with a history of COPD and was presumed secondary to their underlying condition and not the actual buprenorphine. And then there were 3 serious adverse events, which were typically in keeping with bradypnea or hypoxia. And these were not identified on chart review to be related specifically to buprenorphine in a time-wise manner. And overall, the median length of stay was 2.4 hours, and a higher dose was associated with a shorter stay in the emergency department. The main considerations just from this study itself is that we can see that there is a rapid symptom resolution when patients received a dose of buprenorphine, especially in a higher dose manner. We need to be cautious with the patients that we are selecting. With this, we need to also have caution with high dose induction in patients that are critically ill or patients that have comorbid conditions because they have theoretically a higher dose of respiratory depression and hypoxia, and the importance of training itself. There are many limitations within the study and previous studies related to this. Limitations include inconsistent documentation, which limits our ability to actually abstract data. Most things that we are seeing apart from the study that I presented are individual case studies or case series, and they're often retrospective, so we do not have any RTCs to guide whether or not this is effective or has a higher benefit compared to other forms of induction. We are just essentially looking at people that receive macro inductions. And we really do not have any long-term data to support that this is something that truly helps someone either reach abstinence or be engaged in treatment or retain doses of their OAT over time. Because there is a lot of variation site to site, for people to adopt this strategy is really dependent on where you live and what resources you have available. So if we take this a step further and say a patient is macro-induced, or we think about administering buprenorphine in a really high dose, what if we were able to give them something like Sublocade, an injectable form of buprenorphine, which would typically have a peak within the first 12 to 24 hours. General recommendations as of 2022 as a product Monograph for Sublocade was that a patient was recommended to have at least 7 days on a stable dose greater than 8 of buprenorphine or Suboxone before they would be considered to receive Sublocade. But we're seeing that that is changing and it has changed over time. In a 2023 case report of 2 patients diagnosed with opioid use disorder with documented daily use of fentanyl, who presented to the emergency department. They reported a 26-year-old female that presented an opioid withdrawal after receiving a dose of buprenorphine in community that they used from their partner, and a 46-year-old that presented initially not an opioid withdrawal, but with a desire to be induced onto buprenorphine. Both patients had experience with OAT prior to presenting to hospital. Initial COWS score for the patient that presented in withdrawal was 18. And for the patient that ultimately was held for 18 hours in the emergency department, they subsequently had a COWS score of 25. When they had these COWS scores, it was felt that the timeline and their withdrawal was severe enough that they received doses of 4 to 16 milligrams titrated over 24 hours, with the day 1 total for both patients being between 28 and 32 milligrams over the first 24 hours. They then, the following day, received a 32 milligram dose of Suboxone or buprenorphine, and after that, immediately received a 300 milligram dose of Sublocade. In a follow-up to this, after they identified that there was no sedation, no precipitation, and that this was something that could be done in a safe way, in a feasible way in the emergency department, the same group published a case series of retrospective review of the patients that received this protocol over time between January 1st and December 31st of 2021, with a total amount of patients being 90. Their main goal was to compare whether or not the incidence of overdoses, ED visits, hospital admissions at 1 year was comparable or different between the 1 year prior to their index visit and the 1 year following their index visit and after they received this high dose induction with Sublocade following that. They looked specifically at the total dose of sublingual buprenorphine received during their induction, their overall length of stay, adverse outcomes, and treatment retention at multiple monthly intervals, and overall the number of overdoses, ED visits, and hospitalizations. Overall, this study demonstrated that there were no adverse events in people when they were in the sublingual induction phase, meaning no precipitation, no sedation during what would be classically considered a high dose induction. The median sublingual dose, because there is no upper limit within this protocol, was generally 95 milligrams and a mean of 35 milligrams per day. Mean time between formulations, meaning between the sublingual induction to Sublocade, was 65 hours. 21% had at least one fewer overdose event the 1 year following. 78% had at least one fewer ED visit. 76% had at least one fewer admission. And at 3, 6, 12 months, there were varying degrees and decreasing degrees of retention to care. But outside of this, they were able to identify that for patients that received this dose, the next subsequent follow-up that they had at least one dose following that, meaning that if they received Sublocade, everyone received at least one additional dose following that, with a maximum of 12 for patients followed for a year, and that a median of injections for patients was 4. Additional studies have been done. One in 2023, which is an open label rapid induction pilot study, which additional clinicians, researchers have taken same day ER buprenorphine to say whether or not whether this and a macro induction is actually required. All this to say, does someone have to receive a macro induction before they receive Sublocade in the emergency department? This study was based out of Berlin, New Jersey. There were a total of 26 enrolled, and it was performed, and data was pulled from 2019. These studies looked specifically at low-dose buprenorphine, meaning that they received around 4 milligrams and subsequently received Sublocade if they met inclusion criteria. This is just to show this type of protocol, which was done where essentially they have exclusion factors to identify patients that have a risk of precipitated withdrawal based on the specific opioid they use. And then they subsequently want to know whether or not they're in severe withdrawal. If patient is in severe withdrawal, they meet the inclusion criteria and they've used in a safe time frame from when they presented. They then received a 4 milligram tab of sublingual buprenorphine. They were reassessed. If there's no allergy and no evidence of precipitation measured by a COWS score increase of 6 or more, then they received buprenorphine as an injectable 300 milligram dose. In this, there were patients that did meet exclusion based on the factors that I mentioned in terms of whether or not they're using long or short form opioids. And there were a total of 2 patients that were lost to follow-up. These plots are showing the total COWS scores for patients plotted over time, where day 1 is the date of their Sublocade injection. Hour 0 is when they receive their Sublocade injection. PTM is when they're being induced onto the sublingual Suboxone. In this case, we can see that plotted over time for patients, generally what we see is they receive doses of sublingual buprenorphine, overall have a mild increase in their symptoms, but subsequently when they do have enough of the sublingual buprenorphine, they return to their pre-induction COWS. And then once they receive a injection of Sublocade, following that, their COWS scores continue to improve over time compared to where they were when they initially presented. If we look specifically at different subgroups, this plot is looking to say, where did the COWS score reach its peak? Was this something that happened before the Sublocade or something after the Sublocade? And when patients had a maximum severity post Sublocade injection, they generally tended to have a slower decline in their COWS score compared to those that peaked during their sublingual induction. And that generally by 4 to 6 hours, this would reach the same level and would reach the Sublocade level. And then over time, by 12 to 24 hours, these would reach COWS scores that were equivalent between the groups. Notably, for patients that did have a max that happened after Sublocade, again, this peak happened and it took longer for them to get down to an equivalent COWS score compared to those that didn't. Overall, what this is generally showing is that data is extremely limited in terms of whether or not we can use Sublocade in a safe way in order to rapidly titrate someone onto buprenorphine and also at the same time be cognizant to minimize their risk of precipitated withdrawal. Especially in the case of patients that are also in corrections settings, where buprenorphine often is used very commonly. And in some cases, in specifically a case series that is not yet published within Vancouver and surrounding, the risk of precipitated withdrawal in these types of inductions are much higher compared to those that first undergo a macroinduction followed by Sublocade. Generally, what we're seeing is that Sublocade with a macroinduction is safer than those that do not have a macroinduction prior to, and that these protocols require patients to be in an appropriate setting to monitor and manage precipitated withdrawal should it occur. All of this to say that these studies have actually led to in real time changes within Sublocade's product Monograph. And as of February 2025, the recommendation is that patients should receive an initial dose of 4 milligrams of transmucosal buprenorphine. And if they tolerate this, they can be considered for a dose of Sublocade. So no longer requiring that 7-day period on bup. There are, however, a lot of practical considerations in this because Sublocade is not something we can take back. We need to know that this is a correct medication for our patient, especially because this is going to impact, number one, their desire to stay on it, their desire to try it in the future if they have a poor experience. And it's also going to affect how we prescribe and dispense out following a patient that has received Sublocade and wants to switch their therapy. We also need to be cognizant of the risks of coercion for these patients if we are giving something like an injectable and the risk of it impacting their future interest in engaging in care as well as their interest in something like Sublocade. We return back to the question of let's address the patient populations that we see. We see people in eMERGE, we see people in the pre-hospital setting that are sometimes lost to follow-up or self-initiate discharge. How can we go even further to target these and try and engage and stabilize these patient populations that are so high risk? When we look at the data to address these patients that have increased risk of subsequent overdose, we have to consider the patients that we don't see in the emergency department. This plot is showing BC CDC data from 2010 to 2019, which is showing a proportion of paramedic-attended overdose events where patients declined transport to the emergency department or to hospital. And generally, as we see, this is an increasing trend across all health authorities, and that this increase over time has gone from 2% declining transport to 27% declining transport as a mean around 2019. This is all BC-based data, and it's a prospect cohort study for patients that experience non-fatal overdose within this time frame. In addition to this, people that transported to hospital generally on other studies have shown that they have a lower odds of subsequent overdose within from if they reach a healthcare setting. So if they get to us, generally their risk overall is going to be lower for a non-fatal overdose in the following months. Pre-hospital services are an important point of contact to our patients. They attend to opioid overdose, toxicity, poisonings. They receive calls for our patients that have concurrent opioid use, but might not be actually calling for toxicity or overdose. And they also are frontline seeing patients that we have that have concurrent disorders. Considerations for this Considerations for pre-hospital services giving buprenorphine is that generally reversing opioid toxicity can save patients from overdose, but at the expense of increasing their risk of precipitation following naloxone. Patients are at higher risk of precipitation in an outpatient setting related to the doses of naloxone they use, whether intranasal, intramuscular, in a dose-dependent manner, and also dependent on who is actually administering naloxone, where some groups have higher doses, which lead to higher amounts of precipitated withdrawal. This is a very high-risk period for patients that do not make it to our department. And there's a larger proportion, as I mentioned before, that aren't making it. So what if we could use this in a pre-hospital setting, and what would that look like? A 2021 study looked specifically at this, which was based out of the US, which was a protocol authorizing paramedics to administer buprenorphine to patients presenting with opioid withdrawal symptoms, specifically those that have these symptoms post-naloxone, and how they can use those to better manage withdrawal symptoms and engage patients in care. Notably, this study, they had a 24-hour paramedic supervisor that ultimately made the decision. So it was not paramedics in field that were truly making the decision to administer this. This is an example of the protocol they use, where essentially similar to other studies, they have specific exclusions related to age, related to pregnancy, and when they last received their opioid of choice for them. And whether or not they received methadone within 48 hours. They then had a COWS score that was applied, in this case 7. If they had significant withdrawal, met those inclusion criteria, the case was reviewed with an overseeing specialist. And then from there, they would be administered a 16 milligram dose of buprenorphine to manage their symptoms. And they would then have repeat reassessment over time as they're transported to the hospital to see whether or not they had any evidence of precipitation. In this specific case, they required 10 hours of contact training in this specific protocol and related to opioid use and the pharmacokinetics of opioid use. Of all of these 18 patients that were enrolled, all of them had symptom improvement post buprenorphine administration. There were no cases of precipitated withdrawal, and that generally on-scene time increased by 10 minutes for patients, which within pre-hospital literature is an acceptable amount of time given how high risk this patient population is. And for this group of patients, they all completed next day follow-up, and 2/3 were retained at 30 days. In a follow-up study following the same protocol, but with much larger numbers of 240, they looked to see how patients that were attended to by buprenorphine administering ambulances compared to those that did not have buprenorphine. Those were divided based on time, and from that, there was a comparison done between the two. All this to say that generally Table 1 characteristics for these patients are consistent across the groups. Primary outcomes, we're looking at reduction in withdrawal symptoms, whether or not they're engaged at 30 days, and their risk of opioid overdose. And they had additional factors to look into a safety and feasibility of this. When we look at the data comparing those that were attended to by buprenorphine equipped ambulances, we saw significant findings that those attended to by buprenorphine ambulances had higher odds of engagement and treatment at 30 days with a adjusted odds ratio of 7.24. And in terms of the other significant finding being that, similar to previous study, if patients were being attended to by a BUP ambulance, they had longer time on scene and longer time to reach the emergency department. Again, in the realm of 9 to 10 minutes, which is previously identified to be acceptable. Similar things are found between patients if we stratify them based on whether or not not by ambulance, but whether or not they received bup or did not receive bup. Similar outcomes in terms of increased odds of engagement at 30 days, and 30, they had a threefold reduction in their COW score pre-hospital if they were to receive buprenorphine. Increased odds of engagement, no change in the odds of overdose between the groups, surprisingly. And outside of this, accepted ED transport in this specific study showed that people that received buprenorphine had a lower chance of actually accepting transport. So what we can take from this is that buprenorphine improves withdrawal symptoms. Within these two studies, it shows increased odds of engagement in care, similar to other forms of OAT that we give within our care settings. There is an increased amount of time, but that this is deemed acceptable within pre-hospital literature, and that there's no change in the odds of overdose thus far. Additional study, 2023, looking specifically within Northern California, a total of 587 patients were enrolled in this study. It was a phased retrospective study that looked between 2020 and 2021, specifically looking at clinical outcomes for these patients. And this specifically is looking at any form of withdrawal, so whether or not it's cessation-related withdrawal or naloxone-related induced withdrawal. Similar type of protocol compared to others, notable differences being they're using 16 milligrams. They are able to review again with a physician and whether or not they are receiving an additional dose, then that will be dependent on whether or not they've reached the hospital or whether or not they're reassessed and found to have ongoing withdrawal. No cases of precipitated withdrawal were mentioned or were identified within the over 500 patients that received this protocol. For patients, the majority had improvement in their symptoms, and those that remain had no change in their symptoms. 50% were retained in treatment by 7 days, 36 by 30 days, and ultimately in follow-up discharge from ED were 86%, and only and none were admitted specifically related to complications related to buprenorphine. 30-day retention, as I said, quite high. Additional study, most recent, 121 patients, again in the US. This was a standardized QA study that was specifically looking to see whether or not they would be able to actually use this type of protocol with patients that have lower COW scores to lower the barrier to receiving treatment in patients that were younger. So in this case, as low as 14, and also to include pregnant patients within their study. This study, the protocol was driven by paramedics, so there was no oversight. It was purely paramedics that were administering buprenorphine. Inclusion for patients that met the criteria, as I mentioned, they needed to be in withdrawal, they needed to have an appropriate amount of time since their last opioid use, and have a COW score greater than or equal to 5 with objective signs. Exclusion factors, as I mentioned. Skip over that. Primary outcomes were to see whether or not buprenorphine itself had any complications, specifically looking at sedation, hypoxia, bradypnea, as well as some additional factors related to safety, which have been reported previously, as I mentioned. Significant findings in this study identified that 75% were transported to hospital, much higher than previously reported. 70% showed an improvement in response to buprenorphine, consistent with previous studies. 2 patients required additional naloxone doses, but that in chart review, this was felt to be related to fentanyl as opposed to buprenorphine. And 47% were discharged with a new buprenorphine prescription. 12% engaged in treatment by 30 days, so very different compared to the previous study. And a median length of stay within the department was over 300 minutes. There were no deaths. Overall, takeaways we can take from this. is that data for pre-hospital buprenorphine is very limited. It is mostly guided by really our own ethical dilemma of we want to provide as low barrier care as we can. We want to prevent overdose for our patients. And it's felt that buprenorphine is the safest medication that would realistically be able to be given by paramedics and transported by paramedics. It's shown safety in terms of avoiding significant adverse events, and that generally the risk of precipitation is low. Patients that are in a pre-hospital setting that do not want to be transported, this gives an opportunity for us to engage them in care if they were not to otherwise reach us. And that protocols are directly driven by politics, engagement, and stakeholders within the local area. Many considerations within the US as to where this can happen and what's been approved. But one of the really concurrent themes across everything that I've mentioned today, both for macro induction as well as pre-hospital BUP, is that exclusions and consideration for patients to minimize their risk of precipitated withdrawal are standard across all. So we really need to pay attention to what our patients are using, when the last doses were, to make sure that we are minimizing their risk and targeting something like what these studies are presenting as their precipitated withdrawal risk, and also having that conversation with patients about the risk and what to expect if it were to happen. There are many, many, many unanswered questions. What protocol is best? Is this better than other forms of induction onto buprenorphine? Does this actually improve engagement and care compared to other forms? So on and so forth. So there are many questions and many directions where this research needs to go before this is a standardized protocol across areas, but it's at least providing the opportunity for us to see that in local protocols, this is actually something that's feasible and has shown improvement in patients that were within these studies. Real-world considerations as a review of many 131 cases within San Francisco. Main concerns that arise are how good pre-hospital services are at calculating COWs compared to people who are more consistently trained in this, as well as whether or not pre-hospital medicine is appropriate to make a quasi-diagnosis of opioid use disorder and opioid tolerance, and what risk that has that they might administer buprenorphine to a patient that does not have tolerance but had an unintentional fentanyl overdose that otherwise they are not fentanyl tolerant. And one specific case of this had a patient where after receiving buprenorphine, they had significant sedation, hypoxia, bradypnea, and required a higher level of care when they got to hospital. And it's just chicken and egg in terms of whether or not this is specifically fentanyl or buprenorphine that led to this. We also have to be aware of the ethical considerations, the importance of informed consent and shared decision-making with these patients, while doing something like a sublingual induction in pre-hospital medicine will potentially tie someone to reassessment and engagement in care and determination of the appropriate form of OAT for them. We also have to be aware of the risks of people in pre-hospital or other settings administering administering subcut buprenorphine to patients that otherwise do not want to be on it. And this is something where there's a risk of coercion and saying that this is the best form of treatment for this patient as deemed by the medical professional. This is just to show that in Canada, in Ontario, this is something that's actively being enrolled and used. So some of the studies that I mentioned today within Timmins, so Northern Ontario, as well as Ottawa and surrounding, are actually implementing this. And as of 2025, I believe, this is actually within the paramedic protocol that they can treat buprenorphine, or sorry, they can treat opioid withdrawal with buprenorphine. And it's really dependent on the buy-in from individual locale as to whether or not this is something that's actually enacted. So it's not standard. My references. Questions?
Thanks, Adam. That was very thorough. That was really interesting. I didn't realize that that this is being rolled out already more widely in Ontario, so that's fascinating. Questions from the audience? Cool. Can you just repeat the question?
I just had a question about that study that was looking at the sublocated and cow score as opposed to sublocated administration, where it kind of down. It went down like within the first like 6 hours quite steeply. Were they getting like PRN Suboxone or anything additional, or is that big of a drop in cow scores expected to be coming from the sublocated?
So Dr. Sugden's just wondering whether or not in the study that looked at Sublocade for patients that received, I'll just pull it up, essentially whether or not the improvement in cows can be specifically attributed to the Sublocade and not additional doses of bupe. I can't recall whether or not that was on their monograph or like on their protocol. I don't believe so, but I would have to double check.
Just curious, like, if the peak is like at 12 to 24 hours, that's a pretty big drop for it to become
yeah, it's probably a lot faster than that. Like they say 24 hours is the peak for Sublocade, but it's probably a lot faster than that. We don't have great PK data, but there's some PK data that's probably within the first couple of hours, and also the experience when people get precipitated withdrawal from Sublocade, it's not 6 to 12 hours after they get the injection, it's within a couple of hours. So it might be, I guess probably that's probably the withdrawal running its course, but I bet probably is the bupe as well.
There's a question online. What are you sharing now?
Sure, I can share my slides.
So you can reach out if you want a copy of the slides. If Adam's happy to share it, this is also going to be uploaded to YouTube for anyone who wants to share on the BCCSU YouTube website. All of our What's New talks are available. I'll ask a question while others are thinking. So what do you see as the barriers to rolling out pre-hospital bupe in BC? Do you see that something coming in the near future, or do you think that there's more caution that is warranted before it goes mainstream?
Yeah, so I think there's definitely more caution just because most of the data that we have is really only unilaterally looking at patients that receive it and no comparison to any other method. And at least within Ontario, I think we've demonstrated that patients that receive this and present to hospitals, sometimes there is a lack of buy-in from local sites, both at the hospital as well as local EHS. And in addition to that, there is also concern in terms of buprenorphine as a medication that's carried within paramedics kind of within their box to manage these patients. I think it's something that will probably come if there is kind of broader evidence to show that this is something that works and will apply specifically to our local patients. But yeah, I think there are still a lot of barriers in terms of buy-in and yeah.
Any other questions from the audience or online? Okay, if not, then thanks once again for a really topical and thorough talk. Really appreciated that. And thank you guys for attending. We'll see you all in the new year.